Well, hello everybody. Welcome to the Child with a Communicable Disease for fall of 25. This is the lecture that we didn't have time to get to that I'd like you to listen through this. This material will be on the exam. Um, what that character figure thing here is in the middle, I have no idea what that is. So, yeah, sorry, no luck. All right, moving on. Infectious disease. So if you if you think about what infectious diseases are, it's probably obvious, right? So obviously things that are going to be spread around through kids. Um, Examples of infectious disease include things like measles and pertussis. One thing to remember, and especially right now, there's been multiple outbreaks of measles in the U.S. in the past few years, in the past year actually, and in the southern tier of New York State in recent years, we've had outbreaks of pertussis. Part of that is primarily among communities that are poorly immunized or not immunized. Most notably the Amish and the Mennonite communities. Sorry, I totally lost track of where I was. Um, anyway, kids, so infants and young children are much more susceptible to infection due to their immature immune systems. Um, Infants have a pretty significantly decreased inflammatory response to organisms, so that makes them more susceptible to illness. And because infants have been exposed to fewer diseases, and then they start to lose that passive immunity that they get from their mothers, the risk of infection is much higher. Sorry, once again interrupted. So the prodromal period is when you have the vague symptoms of the illness just kind of starting, and then you get into the illness stage. The stage of illness will really have those specific infection symptoms. So whatever it is will manifest itself. Then, when the symptoms start to disappear, you enter the period of convalescence, and that's when the patient starts to feel better. This is a graph depicting the period of communicability that occurs during the prodromal and active illness periods of the infectious process. And you can see that as in the incubation period, for the most part, patients aren't necessarily communicable at that point. It's more during the prodromal period and then when they have kind of the full blown illness. And then it kind of fades away again when they enter the convalescent period. So the chain of infection. Chain of infection is when you have the chain of infection, you have a person who is immune or whose immune system fights off a pathogen, and they're not a susceptible host. That person can be exposed to the pathogen, but they don't get sick from it. The single most effective means of breaking the chain of infection is, you guessed it, hand washing. Question. Nurse reinforces home care instructions to the parents of a child hospitalized with pertussis, or whooping cough. The child is in the convalescent stage and is being prepared for discharge. Which statement by the parents indicates a need for further teaching? 1, we need to encourage adequate fluid intake. 2, coughing spells can be triggered by dust or smoke. 3, we need to maintain respiratory precautions in a quiet environment for at least 2 more weeks. Or 4, good hand washing techniques need to be instituted to prevent spreading the disease to others. The answer is number 3. We need to maintain respiratory precautions in a quiet environment for at least 2 more weeks. So no, once they're in the convalescent phase, they don't need the respiratory precautions. Pertussis is either direct contact or respiratory droplets from coughing, and when they're in the active illness stage or the acute illness stage, that's when they're most contagious. So respiratory precautions aren't needed during the convalescent phase. Options 1, 2, and 4, as I mentioned here, are good components of home care instructions. If I go back to, nope, I can't. If I go back to that slide number 4 with the instituting hand washing, hopefully they're not instituting, hopefully it's continuing good hand washing. So there's many types of pathogens that can cause disease in children. So in this presentation, we're going to talk about some of the main illnesses that we see. You're probably already very familiar with the various methods of preventing infectious disease, and it includes all of these. Of course, number one is hand washing, but adequate immunization, proper handling and preparation of food, which should go with hand washing, judicious antibiotic use, because we don't want to develop antibiotic resistant strains of bacteria, things like MRSA, ORSA, things like that. And then appropriate infection control measures, including precautions, isolation, and quarantine, especially during the time that the patient could be contagious. So when taking a health history, you're going to want to ask questions that are going to be insightful to whether that patient has an infectious disease or not. All of these symptoms should be thoroughly investigated. They're going to give you clues as their healthcare provider whether you need to test for certain diseases or place the patient into isolation or use increased precautions. Sepsis. So sepsis is kind of the nth degree of infection, right? So sepsis is an overwhelming body response to infection. It can be triggered by something seemingly simple. I can tell you a story about a kid who got a cut on his knee in gym class and ended up dying from sepsis. Symptoms include or could include tachycardia, tachypnea, high fever, shaking, chills, lethargy, the child just not feeling well. Again, it is potentially life-threatening, so the child should be seen in the ER as soon as possible to start IV antibiotics. And then there's other supportive measures that need to be taken as well, depending on the degree of septic shock that occurs. So that could include vasopressors, IV fluid, things like that. So we talk about the word exanthem and enanthem. So exanthems, which are which with an X is a word for a body rash. Enanthem is a rash that occurs on mucous membranes. So exanthem all over the skin, enanthem pretty much on mucous membranes. So these diseases are characterized by unique rashes, and they're going to help diagnose the disease. Each of these diseases is going to have a slightly different presentation. They all have a hyperlink to a resource with more information about each disease. I'm not going to click on each one of them here, but if you get into if you have the presentation downloaded, you can certainly do that. Roseola infantum is usually a mild illness. It's fairly common in children. Most kids have had it by the time they get to kindergarten. It's caused by different strains of the herpes virus and starts usually with a sudden high fever, sometimes with sore throat, other respiratory symptoms, runny nose, etc., followed in a few days by a rash on the neck and on the trunk. It's usually not an itchy rash. It's a red rash that will subside usually after a few days. Rubella. Rubella is also commonly called the German measles or the 3-day measles. Starts with a mild fever, sore throat, pink eye, and a rash starting on the face. It then spreads to the rest of the body. It's no longer common due to immunization, the MMR. The MMR is the measles, mumps, rubella. That's the rubella part. The biggest threat of rubella is exposure of a pregnant woman to the disease because it can cause severe birth defects in the unborn fetus. Measles. Measles is covered below on a couple of slides because there's been outbreaks in the U.S. in recent years, and you need to know a little bit more about measles. So we'll get more into that in a minute. Chickenpox. Chickenpox or varicella is caused by the varicella zoster virus. Can be contracted despite vaccination, so there can be breakthrough varicella. It has a fairly long incubation period, up to 21 days, and oftentimes the first sign of it is an extremely pruritic rash, so a rash with pustules basically, that starts on the trunk and then spreads to the rest of the body. Rash is notable because there are multiple stages to the lesions. There's macules, papules, vesicles, and then they crust over. Once they crust over, the person isn't contagious at that point, so they're considered non-contagious. The biggest challenge is keeping kids from scratching, which can then lead to a bacterial superinfection. So some of the things that they recommend or can be recommended, oatmeal baths may be soothing. A lot of times we'll use like calamine lotion. That can help as well. An adult that gets chickenpox runs a fairly high risk for pneumonia. And there's other potential complications that are listed out in the hyperlink if you click on it. Herpes zoster, which is also known as shingles, caused by the same virus that causes chickenpox. So anyone who has had chickenpox is at risk in later life for it recurring as shingles. Shingles causes a painful, itchy, burning rash along a dermatome. So think of the areas of the skin where if you could see me demonstrating this, where the sensory nerves come from a single spinal nerve. Most oftenly, we'll see it along the face, the head, and ongoing pain at the site of the original lesion. The pain can be debilitating and can last for weeks or months. There is a shingles vaccine. I can tell you from experience, the shingles vaccine is not fun either, although it is significantly less not fun than actually having shingles. The shingles vaccine for me, I think, was probably one of the worst adult vaccines that I've gotten, with the kind of, I don't want to say side effects or after effects, but it just made me feel really, really lousy for about a day or two. All right, measles. So we'll talk about measles. Because of a lack of immunization in people, there's been a reappearance or kind of recurrence now of measles. So at one point we had herd immunity. Herd immunity is when enough people have had it or have had immunization that it's not necessarily common in the public. However, that herd immunity has now decreased, and outbreaks have occurred there was a fairly large outbreak, and I want to say it was downstate in New York in 2019. One of the hallmark symptoms of measles, and I feel like we've talked about this before at some point, are called Koplik spots. And they appear usually 2 to 3 days after the symptoms begin. They're red spots with white centers that appear in the mouth, on the mucous membranes, and usually before the body rash appears. The rash itself for measles appears usually 3 to 5 days into that prodromal period and after the Koplik spots have appeared. So the Koplik spots first, then the body rash. Measles can lead to serious complications. The CDC website, that's hyperlinked back where we had that list of illnesses, will talk a little bit more about the extensive list of complications. Measles, when patients have measles, when you're caring for a measles patient, you're using airborne precautions. So gown, gloves, mask, shield or goggles, N95, or a PAPR, which is the positive air pressure, um, positive air pressure something, um, and a negative pressure room. Remember, negative pressure, because we want clean air sucked into the room. We don't want the dirty air to be blown out of the room. This is a child's back who has had the measles or who has measles, and you can see the red rash that forms. This is varicella or chickenpox. So you can see the macules and papules. Um, they're not they're not vesicles yet, and they haven't crusted over. They usually do crust over and fall off actually within about 2 to 3 weeks. I'm sorry, 1 to 2 weeks. Um, Treatment for it, it's pretty much symptomatic. Comfort measures, rest, encouraging fluids, use of calamine lotion, oatmeal baths, something to ease the itching. They don't recommend necessarily like Benadryl cream because again, kids can absorb a fair amount of Benadryl through their skin. So trying to use some of the over-the-counter things like calamine and oatmeal baths is better for the children. Herpes zoster or shingles. So this is what a shingles rash looks like. Notice how it follows kind of a skin dermatome in a line. The rash itself varies in each patient, but you can just see by looking at this looks painful. It makes me cringe. Shingles is usually treated with antivirals such as acyclovir, and that helps to shorten its length and lessen the severity of the symptoms. This is fifth disease. So with fifth disease, they get this slapped cheek appearance. So like the ruddy redness on this child's cheek. You can see how someone who doesn't know about the disease might just think the child's been slapped or is flushed for some reason. A few days later, this rash will travel down the trunk, down the arms and legs, and usually last between 1 and 3 weeks. Treatment can include Tylenol if they have a fever and or joint pain, which they might, and then comfort measures for the rash. Other viral infections in children. So these are some other viral infections that can cause some notable diseases in children. Polio. Polio has been considered to be eradicated in the U.S. since 1979. However, there's been outbreaks in other parts of the world. Someone who has never been vaccinated is at risk for contracting the disease from someone who brings the disease into this country. The symptoms for polio are often fairly mild, but what most people think of as polio is the paresthesia, the paralysis, and the potential meningitis that can occur with it. Post-polio syndrome can occur in polio survivors anywhere between 15 and 40 years later, and we do have patients with post-polio syndrome. It causes muscle weakness, fatigue, and joint pain. Anyone know a specific famous person that had polio? I'll give you a second, and then I'll just tell you. Franklin Delano Roosevelt. FDR had polio, which is why he was in a wheelchair during a majority of his presidency. One other note on polio, we say it's not eradicated everywhere. When I first went to India, and that was probably 10 years ago, I actually had to get a polio booster because polio was still potentially, not rampant, but still potentially communicable in the area in India that I was in. So, yeah, it's definitely real. Acute flaccid myelitis, or AFM, it's uncommon, but it can really have some serious neurological effects. It affects the nervous system, specifically the area of the spinal cord gray matter, which causes the muscles and the reflexes in the body to become fairly weak. The virus itself sometimes is unknown, but the Coxsackie virus, Coxsackie, remember, is hand, foot, and mouth disease. Coxsackie virus has been found in the CSF in some patients. Rabies. Rabies. Rabies is something that nurses need to be aware of, both to teach both prevention through pet vaccination and teaching children not to pet a wild animal. As tempting as it may be, they should not be petting wild animals. We have rabies out in this area, especially in raccoons, foxes, and bats. There is no cure, so prevention is a key. West Nile virus is the most common disease spread by mosquitoes. About 1 in 5 people who are infected develop a fever and other symptoms. About 1 out of 150 infected people develop a serious, sometimes fatal illness. There's no vaccine to prevent West Nile or medications to treat West Nile virus. The way to avoid West Nile virus is to avoid mosquitoes and the mosquito bites that can potentially transmit it. Mumps is a viral illness. It starts with flu-like symptoms, usually fever, muscle aches, fatigue, headache, and perhaps loss of appetite. After those symptoms, the parotid glands, which are the glands that produce saliva, the parotid glands swell, causing puffy cheeks and a tender, swollen jaw. So that's classic for mumps. If you ever see a question about that, it's the parotid glands that are affected in mumps. Complications let me try that again. Complications are rare, but can include things like pancreatitis, encephalitis, and meningitis. The virus itself is covered by the MMR vaccine. Again, the measles, mumps, and rubella. This is the mumps part of it. However, due to lack of vaccination, outbreaks have occurred in the U.S. in the past 10 years. Infectious mononucleosis, or mono for short, is caused by the Epstein-Barr virus. Spread through contact with saliva, it's also known as the quote-unquote kissing disease, and most commonly occurs in 15 to 24-year-olds. it's a classic. It turned into a classic disease for college age students. Sorry. Um, Symptoms include fever, inflamed throat and tonsils, enlarged lymph nodes, extreme fatigue. Splenomegaly and hepatomegaly are also common, which would mean limiting participation in contact sports. So if a kid is diagnosed with mono, because of the potential for splenomegaly, they could end up with splenic rupture if they have any kind of trauma, blunt trauma to their abdomen. So we don't want that. So they would be restricted. It's primarily treated with fluids and rest. There's really not a silver bullet to fix it. Um, from a nursing standpoint, we should teach prevention through not sharing glasses, toothbrushes, etc. You crazy college kids. This is what it looks like. Um, People will often look at a throat like this and say, wow, it looks like strep. Strep is a little bit more streaky than patchy, I guess I would say. And strep doesn't, surprisingly enough, doesn't always have the white purulent discharge from the tonsils. Ugh. A child with rubeola or measles is being admitted to the hospital. When preparing for the admission of the child, which precautions should be implemented? Select all that apply. Enteric, contact, airborne, protective, or neutropenic? The answer is contact, airborne. So remember we talked about airborne primarily. So with airborne precautions, usually I want to say you're usually going to do gown and goggles anyway. But for the airborne precautions, you're doing an N95, gown, goggles, and gloves. You want to make sure that you're following contact precautions as well, which would be gown and gloves. Um, if things are contaminated, we would bag them and label them. We would also isolate all the equipment in that patient's room to stay in that patient's room. All right, moving on. Bacterial infections. So kids are obviously very much susceptible to bacterial infections as well. Of course, strep throat is probably the most common and well known. Scarlet fever. Scarlet fever usually occurs with strep throat. Patient develops a bright red rash covering their body that looks somewhat like a sunburn. And like other bacterial infections, it does respond and is treated with antibiotics. Staph infections include things like cellulitis and MRSA, which you should be fairly familiar with. Scalded skin syndrome is a serious skin infection that can affect infants and children through age 6 or thereabout. Some strains of the bacteria, Staphylococcus aureus, um, will release a toxin that travels through the bloodstream and then binds with a protein on the outer layer of the skin. It causes the skin to get red all over and blisters to break out. Most people over the age of 6 have an antibody to this toxin in their blood that stops this from happening. However, babies and young children often don't have those antibodies, and their kidneys are also immature and they can't flush out the toxin. So it's treated with antibiotics and ointments, usually resolving in about 10 days. Impetigo is a skin infection that's common in young children. It's easily spread with close contact. It appears as lesions and crusty blisters, usually on the face. Teaching parents to keep the skin clean and dry, and not to apply antibiotic ointment if ordered. So sometimes they'll prescribe an antibiotic ointment if the lesions are blistered open. There's a typical picture on the next slide of impetigo. Right there. So you can see how it kind of gets crusty on the kid's nose and on his lower lip. It almost looks like chickenpox, but it's much more clustered than chickenpox, and then it's not like systemic like chickenpox. So if a kid first started with this, you might think chickenpox, but it will present itself a little bit differently. Other bacterial infections include these four. Diphtheria. Diphtheria is gone in the U.S., but is still present around the world. It was once the leading cause of childhood death in the U.S., but vaccines have eradicated it. It is part of the DTaP vaccine, diphtheria, tetanus, and pertussis vaccine. It causes the death of respiratory tissue and the development of like a pseudomembrane throughout the mouth, the nose, and the tonsils, which lead to difficulty breathing and swallowing. Whooping cough, or pertussis, has shown up again in outbreaks in our area in recent years and is not an uncommon illness due to lack of immunization. It's caused by the Bordetella pertussis bacterium. It is most dangerous to babies and young children due to their small airways, and it can be lethal in those kids. Symptoms start like a common cold, but the patients develop these severe, I would say, paroxysmal, so they can't stop coughing, these coughing fits, which usually end up in a whoop as they try to get a good breath at the end of the coughing spell. I would do it, but this is recorded and I don't want to hear it the rest of the semester. Um, Older kids, teens, and adults, if they get it, they may not realize they have pertussis, so they sometimes will pose a danger to babies and young children who are not adequately vaccinated. It's treated with antibiotics, and if you're exposed to it, BTW, you should be treated with prophylactic antibiotics. I may have told you the story, but right before, I think it was right before like Christmas break or Thanksgiving break, one of the breaks, I transported a kid from somewhere down the southern tier with pertussis. We didn't know he had pertussis. He tested positive, so I got my 10-day course of erythromycin to take and break with me wherever I was. Tetanus or lockjaw, it's what everyone warns you about if you step on a rusty nail, right? Sometimes it's the only symptom is that you can't open your mouth. So if you're caring for this patient, you really have to keep a trach kit handy, because if they vomit or have trouble breathing, there's really no way to suction or intubate them. It really does lock their jaw into place. It causes muscle spasms, also, especially the jaw, muscle stiffness throughout the body, fever, trouble swallowing, um, tachycardia. It's treated with an immune globulin like IVIG, antibiotics, and supportive therapy until the symptoms subside. Vaccination to prevent this illness is important. So things like the DTaP or getting your tetanus renewed or your tetanus boosters is important. Lyme disease, bacterial infection, most often transmitted through a tick bite. Symptoms include fever, headache, fatigue, and a bullseye rash, which I'll show you in a second. If it's left untreated, the infection from Lyme disease can spread to joints, it can spread to the heart, it can spread to the nervous system. It's treated with antibiotics, specifically doxycycline. Preventions through teaching kids and adults to use caution when outdoors, wearing long pants in grassy or brushy areas, tucking pant legs into the tops of their socks, treating clothing with permethrin, which is an insecticide that you can spray on your clothing and equipment and stuff like that to keep ticks off of it, wearing insect repellent on their skin, and then always checking yourself or your children for ticks when you come indoors, and really also checking pets, because the ticks can obviously ride on the back of the dog or cat or whoever and come into the house and then can infect people. So check pets also. So this is called erythema migrans. This is the classic bullseye rash that we see with Lyme disease. It's again, most often the result of a tick bite. Sometimes, though, a black fly bite can look very familiar to this. So anyone with this rash should see their healthcare provider immediately for treatment. And again, it's usually doxycycline, or sometimes it's amoxicillin. Then there's vector-borne infections. So vector-borne is kind of what Lyme disease is. Um, another disease that is spread by ticks is Rocky Mountain spotted fever. It's one of a group of infections called rickettsial diseases because they're from the rickettsii organism. Rocky Mountain spotted fever is fairly widespread throughout the U.S. It's also treated with doxycycline and can be deadly if not treated. Vector-borne infections. So vector-borne basically means that it's like from a tick or a mosquito or something like that. Include West Nile virus, which you talked about already, and malaria, which isn't common in the U.S. except through travel and immigrants. Malaria, I can tell you a brief story about malaria. We, in our ICU somewhere that I worked, and it's going to remain nameless, not strong, that had a outbreak of malaria, or had a transmission of malaria. Our kid came in and was positive for malaria. So he was treated, and then, gosh, about a week or two later, another kid had malaria, and we're trying to figure out how are these kids getting malaria? Well, the one had traveled and got malaria from wherever they had traveled to. The other kid, though, was in the same hospital room, but malaria is transmitted usually by mosquitoes or something. So we wondered, is there a mosquito that bit the kid, bit the infected kid, and then bit the non-infected kid? Anyway, to make a long story short, it was at the time that, and again, this is back in the day when we first started to get saline flushes, like the pre-made saline flushes. Before that, we always just made up our own saline flushes. So we had the pre-made saline flushes, and in this particular unit in the room, there was a med cart, and you would keep your stuff on the med cart, right? So one of the nurses didn't use their entire saline flush on the patient that had malaria. They used part of it and then took it off and put it down. Well, the other nurse in that room picked up that syringe and used it to flush their patient's IV, which gave them the bloodborne pathogen from the other patient and infected them with malaria. So, if you're using half a flush, toss the rest of it. Don't hang on to it. Kids can also get exposed to parasites like lice. If you work in peds, you're bound to come across a child with head lice, and you'll be treating families with how to deal with it. Your book does a really good job discussing both scabies and lice. The bad thing with lice, and obviously I don't have to worry about it as much anymore, but the bad thing with lice is that sometimes you don't realize it until you're like already knee deep or elbow deep in patient care, and then you see like the bug crawling around on the scalp or something like that, and you wonder how long that's been there. Makes you itchy. Helminths. Helminths are parasitic worms. They're easily picked up by children because they frequently put dirty hands in their mouth. Many, excuse me, many of these parasites are picked up from playing in the dirt or eating vegetables that haven't been properly washed. FYI, wash your vegetables. Pinworms are one of the most common intestinal worms in the U.S. and around the world, easily transmitted from person to person by the fecal-oral route, again gross, via dirty hands, bed linens, or toys. Pinworms can be diagnosed by looking at a sleeping child's anus with a flash. I only chuckle because this actually is the process that you use. Diagnosed by looking at a sleeping child's anus with a flashlight about 2 to 3 hours after they fall asleep, because the pinworms lay eggs in the folds around the anus, and it can be visible with a flashlight. Children also experience anal itching with pinworms. Treatment for all helminths involves medication and thorough cleaning of the items that may be involved in transmission. Teaching children good hand washing is also essential. Other infections, so giardiasis. Giardiasis is worth noting because we had a large outbreak of it in our area a few years ago. It's most often found in water contaminated with the parasite Giardia, but it can also be transmitted via the fecal-oral route. Again, gross. Symptoms include diarrhea, abdominal pain, nausea, upset stomach. It's treated with medications and interventions for dehydration. The fungal infections here listed are also common in children. Your book provides good pictures of these fungal infections. Tinea pedis and Tinea corporus are treated with topical antifungal cream. Tinea capitis is treated with an oral antifungal. Teaching prevention of transmission is really important, and it's outlined again in the book. So this is what Tinea corporus looks like. Classic. When you see it, you'll instantly say that you know that it's ringworm. Other fungal infections, so candidiasis. It's a fungal infection that will show up in the mouth as white patches, known as thrush. We talked about it when we were talking, I think, in adults in 4600 about HIV. Those patients can develop candidiasis. and they can also develop that hairy leukoplakia. It can also cause a diaper rash, so you can get candidiasis in their mouth. They can get it on their behind, in the perineal area. Nystatin is a treatment of choice orally for thrush and as a topical cream for the diaper area. And for orally for thrush is usually a swish and spit, or if you have a patient that can't swish and spit, like painting it onto their tongue or the inside of their mouth. A child hospitalized with Rocky Mountain spotted fever. The health record reveals documentation that the child was bitten by a tick 2 weeks ago. Child presents with complaints of headache, fever, anorexia, and the nurse notes a rash on the palms of the hands and soles of the feet. The nurse reviews the primary healthcare provider's prescriptions and anticipates that which medication should be prescribed: ganciclovir, amantadine, doxycycline, or amphotericin B. The answer is doxycycline. So doxycycline is the classic medication that's used to treat Rocky Mountain spotted fever. Also Lyme disease. Amphotericin B is for fungal. Ganciclovir is for cytomegalovirus. And amantadine is actually used to treat influenza A. So fever. So everyone is concerned about a fever, right? So fever is a common symptom in sick children. And understanding the process by which the body increases its set point, the temperature it thinks is appropriate, leading to symptoms of fever, is often important in effective treatment. Fever is actually useful to the body in that it's part of the immune response to invading pathogens. Because fever can actually be useful in the immune response, lower grade fevers may not be treated unless a child is extremely uncomfortable. So when we talk about like not treating a fever of like 38.0, waiting until it gets to 38.5, it's not to make the kid miserable. It's because it actually has a function to it. Kids who have experienced febrile seizures are usually treated to keep fever minimal. Because of fever, though, the body can have a large insensible water loss. So we can, it's why encouraging fluids for many of these viral illnesses is really important. The child who experiences diaphoresis or sweating when a fever breaks needs to be kept dry with fresh linens and fresh clothing to prevent shivering, and then an increase in temperature due to the shivering response. These are just some of the interventions that we would use nursing-wise. Again, for kids who are really, really itchy, or have the pruritus of a rash, oatmeal baths are sometimes helpful. Gloves and hand washing to prevent transfer of infection from contact with the patient. Again, you can certainly end up with it yourself. So when a child has a infectious disease, it's important to just kind of think about these teaching points. So, and these are pretty common for most kids and most illness teaching in general anyway. Um, when you're talking to the child, though, think about the last couple things. So teach to the level of understanding of the child if you can. Provide some sort of reinforcement and rewards, like hand washing or something like that. And then sometimes it takes multiple modes of learning involving many senses: watching something, hearing something, doing something. It may take all of that. Teaching the guidelines for tick removal. I've got a tick. What do I do? Well, here's a good plan for you. So using fine tip scissors, you want to not infect yourself with it. Grab it as close to the skin as possible and pull upward with steady, even pressure. Don't twist it, don't jerk the tick, and once it comes out, clean the site with soap and water and wash your hands, and then save the tick for identification in case the child becomes sick. Because again, they're not going to become sick instantaneously when they are bitten. Immunity. So two types of immunity that we talk about: passive immunity and active immunity. Passive immunity is what kids get from maternal antibodies. It's passive. They get it. They don't have to do anything to get it. They just get it. Active is either from your own infection or vaccination. So these vaccines are all commonly given during childhood. Many of them are given in combinations that require fewer shots being given at any one time. The 3 FDA approved COVID vaccines are available for all children. Actually, now I think it's 6 months of age and up. Um, yeah. You need to know the different types of vaccines. FYI, you need to know the different types of vaccines. The types are described here. As you can see, most of the vaccines are produced from non-living material. So contracting a disease from a vaccination is not possible in cases like the flu shot. When people say the flu shot always gives me the flu, that is not true. The polio vaccine also has an oral form, however, and that form is a live vaccine. And that's actually caused known cases of polio to develop. So in this country, the polio vaccine is given as a shot. There's a reference on the course website showing doses, routes, sites, and needle sizes for various vaccines. A lot of the public health or pediatric nurses consult a reference like this whenever they have to give vaccines. It's not a bad idea because sometimes things change. There's also a link on the course website to the CDC site for vaccine information statements. Under New York State regulations, a VIS or a vaccine information statement must be given to the parent or the patient for every vaccine given. This is a resource that the public health agencies, the clinics, the physician offices use to meet that requirement. You get a VIS whenever you get your flu shot. And then most people throw them away. If you click on the hyperlink here for the vaccination schedule, you'll see the recommended vaccination schedule for children. There's many vaccinations given in the first few years of life, and it's understandable why parents have become upset with the many shots that their children have to have. Question. Mother brings her 4-month-old infant to the Well Baby Clinic for immunizations. Which immunizations should be administered to this infant? So, yes, you should look at the vaccine administration schedule and be familiar with that for the exam. So, should this patient get the diphtheria, tetanus, or DTaP, measles, mumps, rubella, and inactivated poliovirus? Should they get varicella and Hep B? Should they get MMR, Haemophilus influenza B, and DTaP? Or should they get DTaP, Haemophilus influenza B, inactivated polio, and pneumococcal? Answer is 4. So the first dose of MMR is administered between 12 and 15 months of age. The second dose is administered at 4 to 6 years of age. If the second dose wasn't given by 4 to 6 years of age, it should be given at the next visit. The first dose of Hep B is administered between birth and 2 months. The second dose is administered between 1 and 4 months, and the third dose is given between 6 and 18 months of age. Varicella zoster is administered between 12 and 18 months of age. So at the 4-month time, you're giving the DTaP, the Haemophilus influenza, the inactivated polio, and the pneumococcal. Another question. Nurse prepares to administer a measles, mumps, and rubella vaccine to a 5-year-old child. How should the nurse plan to administer the vaccine? IM in deltoid, sub-Q in the gluteal, sub-Q in the outer aspect of the upper arm, or IM in the anterolateral aspect of the thigh? The answer is subcutaneously in the outer aspect of the upper arm. So MMR is one of the vaccines that's given subcutaneously in the upper arm. Child should get 2 vaccinations, the first between 12 and 15 months, the second between 4 and 6 years, or 11 and 12 years. Following statement, true or false? The nurse accurately explains to the parents of a child with a fever that antipyretics will help change the course of the infection. So giving them Tylenol or ibuprofen will help change the course of the infection. False. Antipyretics don't do anything for the course of the infection. They give symptomatic relief, but they don't change the course of the infection. So the best part about trying to control a fever is more comfort, less fluid requirements, things like that. But it doesn't shorten the infection by any means. These are some resources. There are some good questions on the Quizlet that's here as well, so feel free to take a look at that. otherwise, that's the end, and I appreciate your attention. Thanks.